So what do we need to do if we do an angiogram? And I explained before, we don't need to do an angiogram, a diagnostic catheter angiogram, or put the children through it, and it's always done under general anaesthesia. We don't do a diagnostic study unless we're actually going to undertake embolization treatments. If you're doing these in babies, you always risk the problem with small vessels and injury to small vessels. You want to keep your portal patent. You want to keep those access sites patent, so you do not want to do unnecessary angiography on any child of any age. And so when we do an angiogram, for example, in that girl I showed you with the one extremity that was slightly larger than the other, you really need to do a global angiogram, so you need to put the catheter up in the axillary artery, and at that point inject and really evaluate the whole of the limb from the top of the extremity down to the fingertips. And then selectively look at the area where you think the abnormality is. So we selectively go into the radial, the ulnar, and the radial and the ulnar and the interosseous arteries, looking for the nidi. And in fact, you need to look for the nidi because that's where you need to direct the treatment. So you can see the typical features proximally of an enlarged brachial artery, aneurysms here just above the elbow, significant enlargement and tortuosity to the interosseous artery, below the elbow, enlargement to the radial arteries, early draining into large veins in the arm, and the nidi as well. And then when you see the nidi, what you have to do is to really, or what you can do and what is advised, is to identify them so you know how to direct treatment. And when we are treating peripheral arteriovenous malformations, we can treat them transarterially, and we can also treat them percutaneously, and we can also do a combination of both treatments. The advantage of direct puncturing through the skin of the nidi is that you may avoid inadvertent embolization to normal structures, including nerves. If you do it percutaneously, you can direct your treatment straight at the nidi. Not always easy. But for example, there are 3 locations of nidi in the distal forearm and 2 in the palm here. And I know these are not very clear, but the nidal channels are extremely small, and I'll show you them in more detail just now. So if you want to demonstrate the nidus, you can actually puncture. This is one of those lesions in the palm. Here's a little butterfly needle that's put through the skin and contrast injected. We don't do this as a diagnostic. This is part of the embolization procedure. So before when we're doing the embolization, then we would be puncturing percutaneously the nidi. You can see them with a catheter, but it's sometimes really hard to get the catheter, and I found it very difficult in this patient to get the catheter right out very, very close to the nidus in the forearm, and it was easier to do this percutaneously. So what embolic agents in children do we use peripheral AVMs? So if we're puncturing the nidus percutaneously, we can inject alcohol, and many pediatric interventionists really like using alcohol for arteriovenous malformations. I know in adult practice, certainly glue is the favored embolic agent. But these AVMs in children are really difficult to control. They are field defects. We really want to destroy the vascular endothelium. Glue will block the channel. It doesn't actually destroy the endothelium as such. And although glue can be a useful adjunct at times, you can actually inject glue percutaneously as well through butterfly needles if you need to. And sometimes you can use glue to control the venous outflow as well from the nidal channels. And you can inject glue transarterially or percutaneously. We really don't use much in the way of coils at all, I must say. Coils always got a bad name for themselves when they were put in transarterially. But sometimes we may actually use some closure method to control the venous outflow. Often, if this is a representation of a limb, you can control the venous outflow even with an external tourniquet. So if the red represents the artery coming down into the limb, the blue, the venous drainage of the limb, and here's the nidus, for example, and I'm just putting one area here to make it look very simple, which usually it isn't. You can, when you actually inject your catheter down on the arterial side, you need to get it right out to the nidus. And if you can't get it out to the nidus, then if you puncture the nidus percutaneously and directly, you can really focus your treatment on it. You can slow the flow back out from it by putting a tourniquet on, and this sometimes helps during the treatments. during the embolizations. And always, if you're using a catheter to do any transarterial work, I don't mean a diagnostic study, but actually doing any embolizations, injecting alcohol and glue, you need to use microcatheters with a coaxial technique, really. So what does the nidus look like after you've actually embolized it with alcohol? Here is another nidal puncture here, showing the small little vascular channels in the nidus. We're not showing reflux back onto the arterial side, and we're not actually showing outflow onto the venous side, but here again is more filling of the nidus. We then inject alcohol, maybe only half a cc of absolute alcohol, depends, sometimes up to 2 cc aliquots we'd inject at any one time. When we inject it, we then wait 10 minutes and then repeat the contrast, see if we've got closure of the nidus. And here is relatively good closure of the nidus after the alcohol's been injected. Transarterially, sometimes it's more difficult, and if I'm really not out far enough, I really am very concerned about injecting alcohol transarterially, and sometimes I'll inject glue, and here is some glue being deposited. It doesn't look very good, and I've shown you this because we've got a build-up of glue actually too proximally, and we've not got good diffusion of the glue actually through the entire nidus, but this actually did help because we actually used a combination of transarterial glue and percutaneous alcohol injections, and this is what one patient has looked like. We have not finished the treatment in this patient, so I thought it was actually quite good to show what we can achieve by a combination of transarterial glue and percutaneous nidal alcohol injections. Here's the angiogram in that girl pre-embolization. You can see with the nidal locations in the forearm and 2 in the palm. After 1 embolization, this is actually after the 2nd embolization, and now we're actually after the 4th embolization. So you really need to have an idea also of what is your end point of embolizing AVMs. It's the easy answer is why, what is your goal for treatment? So if your goal is I'm doing this because of pain, then once you've eradicated the pain, you've finished your treatment. Because you'll never cure these lesions. You'll be there for the remainder of your life trying to do these lesions, and we cannot offer cures. And so once we eradicate some of the symptoms that are causing the problems, then actually we've often achieved our goal. And what we would do is once we've achieved this, we would then not do any follow-up imaging necessarily or any angiography for maybe 12 months. And then we would reevaluate things 12 months later and see what things were like. Unless, of course, the patients return to us sooner. But usually they don't. So here's a patient, a girl actually, a young teenage girl, who had this AVM all her life, but actually when she reached about 15 years of age, she started getting unremitting pain in her middle finger, and she really couldn't write, she couldn't type, she found playing sports very difficult. She had no skin ulceration, but she was having pain in the middle of her finger, which really was causing major problems for her. So here's the angiogram, here's the diagnostic run just before we've done the embolization. You can see the abnormality in the middle finger with large arteries, early draining veins, and some nidal channels more distally in the finger. These were punctured percutaneously with alcohol, and this is the picture immediately afterwards. She did get a little bit of tissue injury from the alcohol injection, but this resolved and healed well, and her pain resolved and has not recurred for several years.